Good afternoon, everyone. Seeing as it's 4 o'clock, do we want to maybe wait 5 more minutes and just see that that people are here, or we can actually just continue? As I see, there are now multitudes that have just joined in. So, yes, hello. For everyone that doesn't know me, my name is Lizette du Plessis. I recently completed my fellowship training in hematology at Tygerberg Hospital, and I'm now doing some sessions at Groote. So welcome to another session of Deep Dive, and obviously we've got quite a nice session coming up this afternoon with Dr. Karin van der Berg. And just before we proceed to that, let's just do some housekeeping. So just to say that the session is sponsored by SANBS, and then obviously still with the SACHAS and SACITs always assisting us in this endeavor. And you know our team by now. I hope that you do. And thank you specifically for Nicolay for helping me sit here in her office with her. And just to note that all of the sessions are recorded. And I myself found these sessions very useful when preparing for my exams. So thank you for the team for ensuring that those are always up to date. And very importantly, as you can see on the interaction, please make sure that you're muted. It's also happened to me once or twice, accidentally having unmuted myself during and then speaking a whole lot and speaking very loudly during the procession. Let's keep that to a minimum, please. And please make sure that you've entered your HPCS number correctly just to get the CPD points. Just note that you'll only get the points if you attend for at least an hour uninterrupted. I'm assuming if you're here that you're already on the mailing list, but if you're not, use this QR code. Then you can also subscribe to the Deep Dive mailing list, as well as all the other nice things. And then I think feedback is so important. I think all of us are in different stages in our careers and development, and I think it's always good for the people that are organizing these good things for us to know what is applicable, what isn't applicable, what is something to focus on when an update is due, things like that. So I think feedback is important. We are influencing what we hear ourselves. So I think it's a very wise thing for all of us to do. And then just some upcoming events, things to be excited about. I think you can see all of the registrations here for the SASMO and SACITS conferences. And then something that we are all forever excited about is the next Haem Onc. I was actually thinking about it this last weekend and just about how much I always learn and come away with from Haem Onc. So make sure to register as soon as you can, and that we can make sure that we're all building our knowledge together and sharing our clinical experiences with each other. Yes, so for today we've got Dr. Karin van der Berg, and we are going to be speaking about transforming and building the SANBS donor base to ensure a safe and sustainable blood supply, a 20-year journey, which will be very interesting. And just to say something about Dr. Karin van der Berg is just that she is the medical director of the South African National Blood Service. She serves on the board of the SABMR and is an affiliated lecturer at the University of the Free State. She's a member of several of the ISBT, AABB, and the WHO working parties, with her main focus in research being areas intersecting HIV and iron deficiency epidemics and blood donation in South Africa. So I think she's got a lot of interest, and I look forward to hearing what you have to say about a long experience that you have. And it's always worthwhile learning from someone that has decades of experience. Over to you, Karin.
Thank you very much. There's also nothing that makes you feel as old as somebody telling people that you have decades of experience. But thank you very much for that. I will endeavor to, let me just first find the right screen to share. Can just confirm that I am sharing the presentation. Oh,
Yes, you are. Yeah.
Okay, great. So thank you. Yes, I will. Actually, this is not so much me sharing decades of experience as a perhaps a less academic review of where we have come from within the blood services. And specifically, I'm going to talk about SANBS, but to a large degree, this is also true for the Western Cape Blood Service. So I'm just going to stop my video for bandwidth. Okay. So somebody else asked me to do this presentation for for the Tissue Bank Association meeting last year. And I thought that it would be nice to share this with this audience, given the amount of blood products that this particular audience consumes, but also the fact that they often require, or their patients require, chronic transfusions, which brings with it complications that requires one to have a representative donor base to be able to address them. And here specifically, we're thinking about patients who develop alloantibodies, which makes finding compatible blood difficult for them. And often it's easier to find compatible blood within a particular community rather than being dependent on blood from a different community. So I am going to present this talk and speak as if I did all of this work, but clearly a lot of this work completely predates my joining SANBS. And also there was a huge group of people at SANBS responsible for this. So I'm going to try and take you through a 20-year journey in 60 minutes. And I'll start where these kinds of things often start, with the WHO, who did really great work in terms of improving blood safety across the globe and some of the guidance that they recommended. We'll talk a little bit about the challenges and how the introduction of nucleic acid amplification testing in 2005 really changed the landscape, how we were able to transform the donor base, a little bit of what the impact and the outcomes was, and then also maybe just a little lighter look on some of the work being done now more recently. So before I get started on that, I thought I would just take you quickly through what SANBS actually, the SANBS context and our mandate. And when I have people come to visit us, they are often amazed with how big of an organization SANBS actually is. So as many of you know, SANBS operates in all but one of the provinces in South Africa. We are a not-for-profit organization, but really important, we are not a charity. We are registered under the Companies Act. We operate under license from the National Department of Health under the National Health Act. And through the work done by my predecessors, I think I saw Charlotte's name here on the list, specifically Charlotte Ingram and Jackie Thompson, that were the medical directors before me. And we were then able to conclude this during my tenure here. All of our laboratories and donor centers are accredited to some kind of an international standard. So for most of our blood banks and our laboratories and donor centers are accredited to the ISO 15189. Our stem cell clinical apheresis program is accredited to JC, and our immunohematology tissue immunology laboratories have FE accreditation. It's a system that we are very proud of and has really required a tremendous amount of energy, and I must also say doesn't come cheap. We are a near vein-to-vein blood transfusion service. As you all know, we don't actually perform the transfusions, but right up to where we issue the blood, SANBS is responsible for the entire value chain. And we remain financially sustainable through a cost recovery system through which we deliver a fee-for-service model. In general, the private sector, within the private sector, the medical schemes or healthcare funders will reimburse SANBS, and in the public sector, the public hospitals are billed and then reimburses SANBS. There's also about 3% of our patients or our products go to patients who are in private hospitals but who do not have health insurance. And these people are always problematic for us. But as you can see there, about 2,000, it's now closer to 2,800 staff members. We have in excess of 600,000 registered donors, collect almost 20,000 units of blood per week across 70 fixed donor sites. We have about, I'm going to lie now, I'm sure I am, somebody's going to correct me, but we have in excess of 3,000 mobile blood drives per month, from which we collect 680,000 units. And for me, interesting from all of this is that it ends up in 84 blood banks that services more than 500 hospitals, and we issue in excess of 1.1 million blood products a year. So this is a significant operation and has developed over the last 40 years, but in particular over the last 20, 25 years, since the various blood services amalgamated to form SANBS, some 15, my apologies, 20, 25 years ago. I just wanted to put that in context and then to start right up from the start with the WHO guidance, where after the major scandals of the late 1980s, where there were thousands and thousands of patients infected with especially hepatitis B, but also hepatitis C in countries such as Canada, the US, the UK, as well as in Europe, to the extent, in fact, that the medical director of the then medical director of the French blood service was sent to jail for a period of time around relating to this particular issue. The WHO brought out numerous guidance documents on ensuring a safe and sustainable blood supply. And a lot of it focused on the fact that there needed to be processes in place to prevent the transmission of HIV and hepatitis B in particular, and hepatitis C. Hepatitis C has never been a real issue in blood services here in South Africa, but definitely in Europe and the continental US, it was a major problem. For us, it's always been HIV. And one of the key tenets, or one of the key pillars of a safe and sustainable blood supply is the collection of blood from voluntary non-remunerated donors, and importantly, who are at low risk of infections that can be transmitted through blood and blood products. And so if you can then keep that in the back of your mind, and we then move on to the challenges that we faced, the blood services faced in the period between 1996 and 2005, in fact, even before then. But at that time, as you can see from that heat map, Southern Africa was the center of the HIV pandemic. We had prevalence amongst the adult population in excess of 30%. And we needed to collect blood from voluntary donors, and importantly, from how the WHO requires that it had to be low-risk populations. And so the blood services developed a risk management strategy just before the turn of the century that was based on ethnic group, gender, and donor status. And so you can imagine that the majority of the Black donors fell in high-risk categories, And what this meant was that the cellular component were not used. So the red cells of these donors were held in quarantine and would only be used if there was a real shortage. The plasma would be quarantined, and once the donor had returned and tested negative again, that plasma would be used. But for the most part, large numbers of the cellular component of these donations were discarded. Also, very little effort was put into recruiting Black donors. And so the donor base consisted of less than 5% Black donors. So what you can see from this is that, or maybe just to take a step back and to say that the HIV epidemic really fundamentally changed the blood transfusion landscape, not just in South Africa, but across the world. Some estimates were that at the time, 5 to 10% of HIV transmissions in Africa were due to blood transfusions. And in South Africa, as you can see, we had a HIV prevalence in our antenatal clinics that exceeded 30% by the turn of the century, while the prevalence among blood donors was sitting at about 0.26%. But even at that time, with that low prevalence, there were quite a number of HIV transmissions. And on average, there was reported confirmed cases of HIV transmission of about 2 to 6 cases per year. So HIV transmission, even in South Africa at the time, was a real risk. And as a result, the blood services implemented this risk stratification, which really meant that especially young Black females who donated, their blood would be, the red cell component of their blood would be discarded. That strategy worked really well. The HIV prevalence amongst blood donors dropped to 0.05% by around 2003. So it was a really good strategy in terms of limiting risk. As you can see in the panel on the right-hand side, the difference in the prevalence between those donors deemed low risk and then the high-risk males and the high-risk females. So you can see there's a really dramatic difference in the HIV prevalence based on this risk stratification. However, this kind of strategy was not sustainable. And by 2005, there was significant political pressure and public outcry based on this strategy. It was kind of, the whole public outcry was in response to an incident that was reported in the press of the then President Thabo Mbeki making a donation and somebody saying that his blood would be thrown away. Now, that's not completely the story as it happened. It was a publicity, I wouldn't say a publicity stunt, but the president wanted to contribute to ensuring that there was sufficient blood in the country, but he never really intended to donate blood. But that is not how it was reported in the media, and there was this major political outcry. Also, on top of the political limitations, the math just doesn't make sense. You cannot have less than 15% of the population being responsible for providing blood for the whole country. In the long term, this was not going to be sustainable in any event. So there was significant pressure to transform the donor base. However, everybody also acknowledged that we needed to maintain the safety of the blood supply. And so in consultation with the Department of Health, and I don't quite know, but I don't know that the medical schemes were that heavily involved in these negotiations, but the Department of Health essentially agreed that they would fund, through the fee-for-service model the implementation of nucleic acid amplification testing. And there was a significant increase in the price of blood because of this. What is quite remarkable about this story is that in 2005, when this was adopted, this entire testing strategy was implemented within 6 months. There's no ways that we would be able to get something like that done in SANBS today. But I'm told, I wasn't there at the time, but I'm told that people hardly slept. And we had significant help from colleagues from San Francisco, from what was known then as the Blood Systems Research Institute, people with whom we have collaborated over many decades, and who just selflessly offered us all of the help and assistance that we could ask for. Also important to remember, or I think that was quite a milestone, is that at the time, South Africa was the first country in the world to implement this individual donation nucleic acid or NAT testing. The rest of the world at the time was doing mini pool testing, meaning that they would pool the blood samples of a number of donors and test the mini pool. And if there was a positive signal, they would then test the individual donations. Whereas in South Africa, we realized that that would not work for us. And so we implemented this ID-NAT testing. As a result of this, we were able to rewrite our risk strategy in a way that at the time, remember at the time, this is not the policy today, but at the time, if you donated less than 2 donations in the last 2 years, we would only use the plasma component of your blood. And this was now irrespective of your race and gender. If you donated 2 or 3 units in the preceding 24 months, we would use both your plasma and your red cells, but we would not use it for components and for pediatric use. So for your products to be used to make things like pooled platelets or to go to pediatric patients, you would need to donate more than 3 donations in the 24 months. And with this strategy and the implementation of ID-NAT, there was quite a dramatic decrease in the risk of HIV transmission. So you can see there that there was a logarithmic reduction. And in fact, from the implementation of NAT, there's been only one potential case where we were able to confirm that the patient likely contracted HIV through a blood transfusion. No other cases have been confirmed. That's not to say that there weren't any, just that we were not able to confirm them, remembering, of course, that we are transfusing into a population that has a very high HIV prevalence. Work that was done by one of the SANBS employees, in fact, suggested that around 40% of patients who receive blood are already HIV positive. So there may well have been other transmissions into patients who were already HIV positive. So with the implementation of this ID-NAT testing and this new risk strategy, SANBS was able to then really reassess how it could be how it could transform the donor base. So, and we did really well. Over the 20-year period since the introduction of ID-NAT testing, we have grown the donor base significantly, and the proportion of Black donors has also increased quite significantly. And so I'm not going to spend too much time on these because the next slides show this much better. So if we look at the donor panel, now the donor panel means a donor who has made at least 1 donation in the preceding 12 months. So we went from where we were just over 300,000 donors in 2005 to nearly 650,000 donors in 2025. So a really big increase. You'll see the dip there in 2021, which was related to the COVID period, where we lost about 20% of our donors. But you can then also see that, especially from 2024 to 2025, there's been quite a dramatic increase in the donor panel. What's important around this growth in the donor panel is the exponential growth in the Black donors. You can see that in 2005, there was probably around, what's that, about 25,000 Black donors. And there was a steady increase. And then in 2018, you can see specifically quite a dramatic increase in the Black donor, or the proportion of Black donors in the donor panel. And I'll talk a little bit about that. And then you can see that the work is just after COVID, this has just increased dramatically. You can also see that there's a slight decline in the overall proportion or number of white donors, but it is, I mean, we went from about 250,000 to about 200,000 white donors, and that can be explained around the fact that we shifted focus from traditionally white areas to traditionally more Black areas. And then maybe just to have one more, I do so like data, to show the actual number of Black donors on the donor panel and how that has increased from what I said was around 20,000 donors in 2005 to over 350,000 donors in 2025, to the point now where our Black donors make up more than 50% of the donor panel. Now, the continued transformation of the donor panel to where there is equal representation of donors according to the race group distribution in South Africa is unlikely to occur. And I'll briefly touch on that. But it comes with significant challenges, and I'll just briefly touch on that just now. So the obvious question is, how did SANBS do this? So really two things. The key was a change in how we recruited new donors, and then very actively managing retention of donors. And here I have to give a lot of credit to our collections teams who have done a lot of work over the decades to get this to where it is today. One of the key things was prioritizing donor education and recruitment. And so in the late 2010s, I don't know what you call that, but around 2010, thereabouts, SANBS received PEPFAR funding, and I'll talk about that in the next slide. But we appointed 14 donor educators across the SANBS footprint whose sole purpose it was to go to especially schools and workplaces to provide training and education to especially to the school children and the university students. We developed and used standardized education material, and these activities were very closely monitored to make sure that there was actually a return on the investment. And then, of course, a lot of focus was put into young people and then new blood drive education. And so with the PEPFAR funding that SANBS received over that period, we trained these educators, but also our collection staff, to be able to provide one-on-one and classroom education. As I've mentioned, we ensured that we had educational material that actually spoke to our donors in a language that was And here I'm not talking about like English or isiXhosa or so forth. I'm talking about just the, language that was relatable. Also, and you will see this goes back quite a while, because I think some of you have never actually seen a DVD in your life, but we developed educational material such as DVDs that we would play at the fixed donor sites, but also in the schools, and make available to various communities for them to be able to use it for training. We also really did a lot of work on just making SANBS and blood donation a lot more visible. Important, I think, given all of the funding cuts that happened over the last 18 months or so, at the time, SANBS made a very deliberate decision that all of these activities were absorbed into the SANBS operational budgets. So while the funding was used to start off these things, we only really started things that we knew that we would be able to absorb into our budgets, into our operational processes, so as to limit our reliance on donor funding. And here I have to really acknowledge Ravi Reddy, who is our CEO and at the time was the Chief Operations Officer, for his foresight in this approach. These donor educators were gradually absorbed. They were funded from PEPFAR funding, but then gradually absorbed. And towards the end, we mainly used PEPFAR funding for capital expenditure as opposed to operational expenditure. And as a result, SANBS was not affected directly by any of the funding cuts that emanated from the US and to some degree Europe over the last couple of years. Okay, the second part was expanding the SANBS footprint. One of the key things to be able to donate blood is that you must be able to see where you can go and do this. And it must be close enough so that it doesn't cost you too much money to get to the place where you can donate blood. And previously, SANBS had actively avoided going to areas traditionally considered to be predominantly Black areas. And when we implemented these changes, especially from about 2010, 2012, thereabouts, we really changed this approach. And we made sure that we started going to Black schools, which we never did in the past. We opened up donor centers in townships, and we really just made it easier for Black donors to access blood donation sites. In addition, we've always had a reluctance, there's always been kind of a reluctance to have too many staff, because if something goes wrong, then it's really hard to reduce your staff numbers. Retrenchments is not something that we like doing at SANBS. And but there was a concerted effort made into better understanding exactly how much blood do we need, and the collections and donor relations or donor marketing staff were increased accordingly, and in particular to service these historically Black communities. The other part of this was just improving over time, and they are still not great. I must tell you, they're better, but we're still work in progress, is the self-contained mobile vehicles and mobile setups that we have, just making it even more easy for people to access the donation clinics. The other part, so there's kind of a three-way thing that we did. The first was to really go out and educate young people especially, then increasing our footprint and going to where the donors are that we are looking for, and then a differentiated marketing strategy. So I must say that, and I might be slightly biased, but over the years, SANBS has had some really cool marketing campaigns. But here, one of the key processes that SANBS utilized was collaboration with local radio stations. And those of you from the Eastern Cape, if there are any, you will know that Algoa FM is it's very big in the Eastern Cape. And I have them there because I spent many years of my life working for SANBS in the Eastern Cape and collaborating with groups such as them, really improved our target audience, being able to connect with our target audiences. There were other radio stations such as Mkhonto and various corporate institutions, civil society. Currently, for example, we are doing work with Roundtable, and these kinds of localized collaborations and community-based outreach really helped us to penetrate areas where we had excluded ourselves from in the past. Just some of the different marketing strategies that we had over the years. The one that elicited a lot of discussion at the time was the Ronaldo campaign in 2016. Really worked really well. I must say that Ronaldo at the time made available all of this marketing material for blood service across the world completely for free, which I thought was really cool. And as you can see, that there's kind of an evolution to the look and feel of these marketing strategies. And these are some of the bigger national campaigns. And then there were also smaller local marketing campaigns specifically focused at a provincial and even lower down at a regional or city town level. Okay, so then we had lots of people coming to donate, and careful assessment of our data showed that at the time, in around 2015, there were about 1 in every 5 donors who came through our doors did not make a successful donation because they were deferred for some reason. Now, these deferrals are really aimed at protecting the donor and the recipient. So you don't want a donor to donate if it can be harmful to the donor. And you obviously also don't want to collect a unit of blood that could be have a negative impact on the recipient. Now, what is interesting about how blood services approached this deferral process is that it is based on the precautionary principle that was adopted following the tainted blood scandals in the global north, where if you suspect even just a little bit that something can have a negative impact on the donor or the recipient, then you would rather show the donor away. So there need not be any evidence, just a slight suspicion. And this precautionary principle approach had a very negative impact on donor retention. So there's 2 things that you see when you have, if you defer somebody. So let's say somebody has low iron and you defer them, the hemoglobin is low and you defer them. 2 things happen. Either they don't come back at all, ever, or it takes a very long time for them to come back. And obviously that has a really bad impact on your donor retention, which means you need to recruit more first-time donors. First-time donors have higher prevalences of transfusion transmissible infections. They faint more. They have small veins. You struggle to get the blood out of them. And so you have to keep on investing in new donors because you have such big attrition of your repeat donors. So at the time, we took a very strong view that we need to become a little bit more evidence-based in how we manage our deferrals. There's an entire big book, as thick as a Bible, that provides guidance to our donor staff on who is allowed to and who is not allowed to donate. And through careful assessment of these precautionary-based deferrals, we were able to do two things. Firstly, we abolished quite a number of them, allowing more donors, potential donors, to donate. But also, we were able to reduce the period that we deferred these donors for, because there's also an direct relationship between the length of the deferral and the time it takes these donors to come back. So one of the examples would be that the WHO at the time had a deferral of 12 months for high-risk behavioral activities. But through the implementation of IDNAT, we initially were able to reduce that to 6 months, 4 months, and eventually to what it is now, 3 months. However, one of the things that happened as a result of this is that if you allow more people to donate and to donate more frequently, you do consume their iron. And so donor iron health has emerged as a growing risk and concern for the sustainability of the blood supply. We did a really nice publication, again, if I may say so myself, on the impact that changing these deferrals, our approach to deferrals had, and I won't bore you with the details, but essentially we decreased our percentage of donors that were being deferred from roughly 20% to now at about, depends on how you slice this cake, but around 15 to 17%. And you can imagine that on 650,000 donors, that 3% difference is a lot of units. And this was done without increasing the risk to the blood supply. We also did not see an increase in donor adverse events or any such negative impact. So we were able to implement these changes quite successfully. The other part that we did quite well is the setting and monitoring of collection targets. And so every year in about August, the various groups of people in SANBS gets together. We analyze the data to death, and based on that, we project what we think the country's blood demand will be for the next year. And we then have a national target, and those targets are then devolved down to our zones, provinces, all the way down to the smallest team, that each team has its own target that it must meet. And these targets are set according to collections from Black donors and collections from new donors. And it gets monitored at the highest level at SANBS, and it also forms part of individual performance targets. Now, the risk with driving an even bigger proportion of Black donors to form part of or to have an even bigger proportion of Black donors on the donor panel is quite an interesting risk. So SANBS, like most blood services in the world, disproportionately uses Group O blood, and then also disproportionately groups Rh negative blood. So we actually, these targets that we set, we first go and look at what the demand for Group O and then Group O negative units will be. And that then determines the demand for the rest of the blood groups. Because we know that amongst the first-time donors, X percentage will be Group O, and we therefore have to over-collect amongst new donors on Groups A particularly, as well as B and AB, to be able to get to enough Group O donors. So that's problematic, but not too bad, because Group O is quite common amongst Black donors. However, we are in particular need of Rh negative blood, and that's where one of the big struggles come, because only about, it's less than 3% of Black donors will be Rh negative. And so the bigger your Black donor pool becomes, the more difficult it is to find sufficient Group O negative donors so that we can meet the demand, for example, the emergency fridges, as well as in emergency cases where we know there isn't time to do blood grouping for the patients. So this is a double-edged sword and is, I'm sure, something put on earth just to make life difficult for the blood services, but it is something that we work on really hard to make sure that we are both transforming the blood of the donor base, but at the same time making sure that we have enough blood, and especially Rh negative blood, to meet the demand. So I'm almost done. If we then just very quickly look at the impact and the outcome. So, and I can speak with great pride about this, in part because until very recently, I played a very small part in all of this. So SANBS was really able to transform our donor base to the point where we have now more than 50% Black donors. Our new donors make up about 15% of all collections in a year. We have a sustainable donor base able to meet the growing demand for blood products. Even though the demand for blood seems to have tapered off just a little bit over the last year or so, there's a growing demand for various different products and services. We were not only able to maintain the overall risk of transfusion transmissible infections, but in fact, the risk has decreased over the last 25 years. We now have had more than 5 days of blood. We had a bit of a dip, I mustn't lie. When I did this presentation in November, this was true, but it's now, there was a short period of time in December, early January, where we dipped down below 5 days cover. But we certainly haven't had any cutbacks. Those of you who operate in the SANBS footprint will know all about cutbacks, although I think the Western Cape also have periods where they are unable to meet the demand. And we were able to really increase the SANBS brand awareness and community engagement. And I really liked this. There was this blood podcast about blood matters. And one of the things that slogans that they use is what somewhere between a tiny poke and an Oscar-winning drama. And I think the work done by my predecessors are much closer to an Oscar-winning drama than a tiny poke. In summary, and this is not the last slide, my apologies, because there was after this something more to say. So this, I must tell you, was a ChatGPT summary of my presentation. Our journey of transfusion, our journey of transformation through connection, collaboration, and communication, where we went from exclusion, because that is what we did, not only based on gender and race, but even up until 2015, based on sexual orientation. We went from risk avoidance to resilience, and from 5 to 50% Black donors. So what's the next thing? Well, in collaboration with our colleagues from the Western Cape Blood Service, we are contemplating world domination. And how we aim to do this is Michelle Vermeulen at the Western Cape Blood Service came up with this really cool idea of a Red Saturday, which usually follows, is it Black Friday? Yeah. So after Black Friday, we have a Red Saturday, and we have a national campaign to collect. The target at the time was 5,000 units. But last year, through work done by one of our colleagues in SANBS, Tabiso Rapodile, we decided to take this even to the next level. And we had a Red Saturday campaign across Africa with the slogan of "One Day, One Continent, One Purpose," which was really, really cool. In the end, we had 15 African countries participated, collected in excess of 22,000 units, with the target that was only 10,000 units. So really did wonderfully well. There was really unbelievable support from countries such as Ethiopia and Nigeria, even in Zimbabwe. And I must say, I was really surprised by Zambia collecting more than 1,000 units. I've been in the country and the infrastructure is really struggling. And so for them to have reached that target was really great. And so with that, I also just want to say that it is with great humility and deep appreciation that I am able to present on this remarkable journey that SANBS has traveled over the past 20 years. And then Ravi, Marion, Simi, and Willem really contributed significantly to this presentation. And with that, sorry, my Rottweiler is trying to eat my mouse. I say thank you.
Oh, thank you, Prof. Dr. van den Berg. This was truly a very, very insightful and worthwhile talk to listen to. I want to give a moment to people who have any questions, just to post them in the chat box. But I firstly, before saying anything about your talk, I just want to say congratulations. Prof. Berg had mentioned in the comments that you've just been appointed CEO of the ISBT. So congratulations for that. And seeing as what you are doing at the like in all the spheres of where you're busy with, we wish you all of the best for that as well. And then I think while I'm waiting just to see if there are any questions or comments, I think the thing that really stands out for me is just that looking back 20 years, or even in your case, it's actually even longer if you're looking at the journey from the HIV epidemic onwards now, and thinking in our own spheres and where we are, how to approach our units with the same amount of diligence in terms of what we want it wanted to look like in 30 years' time. It's quite nice seeing how you as a team managed to really just have so much progress in the last couple of decades. And it's obviously because of a lot of hard work, but it's also good planning and good structures. And I myself am quite just so impressed with what you have managed to do. And a lot of it is just diligence, but also good planning. So I think you have done so well. And thank you for inspiring us as well today, for doing the same in our units, for making sure that we have products that we can offer to our patients who we care for. And yes, is there anything else that anyone wants to comment on?
I think there's a question from Tomek around pathogen reduction.
Oh, yeah, I'm seeing that now. So Tomek's just saying, thanks for the talk. Pathogen reduction is now the next gen technology being used to enhance blood product safety and is being adopted in well-resourced settings. I believe pathogen reduction was considered too expensive to implement in SANBS a few years ago. Would the technology be something that be revisited by SANBS in the future?
Good question. So pathogen reduction technology currently is predominantly used to pathogen reduce, pathogen inactivate platelet products. So you collect a bag of platelets and you do stuff to it. There are two different technologies. The one is where you add either riboflavin or amatoxylin, and then you subject it to the UV verstrahling radiation, and it kind of kills off the bugs. At the time when we assessed this, the cost to implement this was quite prohibitive. And interestingly, at the time, many of the countries that adopted pathogen reduction in the global north were either scaling back or completely stopping pathogen reduction, in that it is really hard to prove cost effectiveness. There are some work being done in Africa to perform pathogen reduction on whole blood units. If you're able to do that, then the cost effectiveness becomes probably better. especially in countries where malaria transmission is a really big problem. But overall, the technology would have to become dramatically cheaper for it to be viable as an option in South Africa. The important factor for me here to remember always is that we all know South Africa has a two-tiered healthcare system. The one thing that I am extremely proud of in SANBS, and which both myself and our CEO, Ravi Reddy, and our entire team feel strongly about, is that blood is donated by all kinds of different people in South Africa. And as a result, the quality of the products that we make available will be the same to all patients. So there will never be a situation of where, well, I mustn't say never, but while we are around, and I take that I will be leaving soon, but I know the team that I leave behind will still feels very much the same. We won't ever have a two-tiered blood system. So the blood products that we provide to the public and private sector will always be of the same quality. And there's just no ways that in fact, either the public or the private healthcare system can afford pathogen reduction at this stage. And personally, and I'm speaking as myself, not as the medical director of SANBS, this technology in my mind is not cost effective. It's not something that I would consider anytime soon. And it's not actually being used beyond platelets in anywhere else in the world except small research programs in Africa.
Thank you, Karin. Could I just get an idea if there's anyone else that has a comment or question? Okay, then I'm going to close the session for us. But thank you again, Dr. van der Berg, for your very thorough and comprehensive talk, and also just inspiring us to do the same in our units. But also just want to motivate everyone here that's listening, and we're quite a few listening today, to all come on board for the next Red Saturday and make sure that we are also donating to this to the platform that we all use. I think that's such a excellent idea. I must say, I saw that Namibia has only donated like 113 units. I'm married to a Namibian. I'll have to speak to him about it.
But it's also only about 200 people in Namibia.
They are very far away from everything. But thank you so much for the talk. Hope everyone enjoyed it. Have a nice week.
Thank you so much for having us. Thank you.
Okay, bye.
Bye-bye.